Good evening, dear friends and delegates. It's a pleasure to have the ICA webinar today, the Wednesday, which we all know. And it is such a pleasure that we are conducting the 252nd webinar, which means a lot of credit to the ICA members and the ICA delegates who are joining our webinars. And we are going to be celebrating the 4th anniversary next month. And the topics that we choose are, of course, several. Just to let you know something about Indian College of Anesthesiology, which you all know, of course, since you join the webinar every week, this Indian College of Anesthesiologists really deals only with academics. So besides the online webinars that you are seeing and which you see on the YouTube also subsequently, are a big asset to the students because they can see them anytime and study them, and of course, which are very helpful for their examination. We've had a very fruitful PG assembly last month at the UCMS, which was very, very fruitful, and there were about 180 delegates, and the feedback was that the students were very, very happy. So this New Delhi PG Assembly will continue, and next year too, it will be held. Of course, we should let you know where it is. It's most probably the Lady Harding Medical College. We are forthcoming. ICA Con 2025 is going to happen in Jodhpur in the end of August. And I request you all to go onto the website and you can all register for it. There is a workshop as well as lectures of extreme importance and varied lectures which you all will learn and enjoy. We have several fellowships which are being conducted by the ICA. To name a few, we have the IDRA, which is the Indian Diploma in Regional Anesthesia, which is actually going on these days at the Sir Gangaram Hospital. We have fellowships from Narayan Vidyalaya. You saw them all being depicted here on the presentation right now during the introduction of the ICA. We have thoracic fellowships, we have onco anesthesia, we have palliative. So again, please take this opportunity, and the students who would like to do fellowships can enroll for them. We have association with ASA and SAMBA. And for those young delegates who would like to go abroad, we have a PG mentoring session as well in the ICA Con at Jodhpur. So please do see these activities of the ICA, take advantage, become members so that you can benefit. Today, of course, every Wednesday, we have very important topics for the students. And today we have bariatric surgery, the challenges and controversies. And we have very esteemed speakers for it. The first speaker will be Dr. Maitree Pandey. She was the ex-head of the Lady Harding, and now she is at the director professor at the RML Hospital, New Delhi. She is a very senior teacher of repute, and of course, we welcome her to the webinar. Maitree, could you please start your lecture, and then later you could introduce all the speakers. Thank you very much.
Thank you, ma'am, for your kind words. So I will be sharing my screen. I think, is it there?
Yes, yes.
Okay. So good evening, ladies and gentlemen. Today, I will be discussing about a very important topic, that is anesthetic considerations for bariatric surgery. And as we all know, that in the last few decades, there is a sharp increase in the rate of obesity worldwide. So more and more patients are coming for weight reduction surgeries, and these patients are considered at high risk. So proper pre-operative planning and meticulous risk assessment is required to decrease the morbidity and mortality in these patients. So in next 15 to 20 minutes, I'll be discussing about the definition of obesity, the various problems in the various systems and its anesthetic implications, what is metabolic syndrome, how the drugs are being adjusted for anesthesia in these patients, and how to optimize these patients before surgery. So normally obesity is described as or defined as abnormally high amount of adipose tissue compared with lean body mass. That is, it is more than 20% over ideal body weight. There are certain weights which needs consideration, that is actual body weight, lean body weight, which is actual minus the fat content of the body. And there are various formulas to calculate the ideal body weight and the predicted body weight. Now, normally, according to the WHO, the very simple definition of obesity is extra body fat to that extent that leads to the adverse effects in the general well-being of a person. Most commonly, body mass index is used to classify obesity, and it has been divided into class 1, 2, and 3 and super obese. If the body mass index, which is body weight in kilogram divided by the height in meter square, is more than 30, it is considered to be high risk. And if it is more than 50, that it is the risk of developing health problems are exceedingly high. So another way to know the risk is to measure the waist circumference. And if the waist circumference is more than 102 centimeters in male and more than 88 centimeters in female, even normal weight patients can be at high risk. And obese class 1 are extremely high risk for surgery and for other health problems. So the common surgeries most commonly performed are restrictive surgeries, which means that laparoscopic sleeve gastrectomy is more common nowadays. The hospital stay is overnight. It has the advantage of lower mortality and morbidity, and there is usually no nutritional deficiency. However, there is a need for more frequent outpatient visits and longest time to achieve weight loss. Next type of surgery is the malabsorptive surgery. In this, jejunal-ileal bypass or biliopancreatic ileodivision is done. For this, the hospital stays around 2 days. It results in significant weight loss. However, malabsorption of essential vitamins and nutrients may lead to protein caloric malnourishment. Other type of surgery is a combined restrictive and malabsorptive surgeries. That is the Roux-en-Y gastric bypass. Hospital stay is longer in this, around 3 to 4 days. And the advantages is there is the greatest weight loss of all types of surgery with improvement in obesity-related health issues. However, there's a need for continuous lifelong nutritional surveillance and supplementation. So these patients have various problems in the cardiovascular system. These patients are usually hypertensive. They have an increased risk for cerebrovascular stroke, peripheral vascular disease. They have decreased cardiovascular reserve, and they have a limited exercise tolerance. As these patients of obese, the metabolic demands are increased, which leads to larger circulating blood volume, resulting in hyperdynamic circulation. And obesity is an independent risk for ischemic heart disease, which is seen more commonly with central obesity. They are more prone for congestive heart failure, cardiac dysrhythmias, and even death. So the pathophysiology, as you can see in obese patients, these patients are having diabetes, dyslipidemia, and hypertension. This leads to neurohormonal changes, increase in RAS, and this leads to renal and sodium and water retention. And on top of that, there is the inflammatory markers and increase in inflammatory markers and increased oxidative stress. All these things lead to increased total blood volume. And this total blood volume increase when it goes to the pulmonary circulation, it leads to pulmonary hypertension, which is aggravated by OSA and OHS if the patient has this syndrome, and eventually leads to right ventricular hypertrophy, right ventricular failure. Increased total blood volume also increases the cardiac output, increase left ventricular workload, along with systemic hypertension and coronary artery disease, may lead to left ventricular failure. So these patients in extreme of cases may show biventricular failure. Coming to the respiratory system, these obese patients have a decreased pulmonary reserve. They have restrictive lung disease. And many patients may have obstructive sleep apnea, and its more severe form, that is obesity, hypoventilation syndrome may be there. And last but not the least, cor pulmonale will maybe also be there in these patients. So in the respiratory system, most of the volumes, lung volumes are decreased. Functional residual capacity and decrease in expired reserve volume is seen. And the functional residual capacity decreases exponentially with increasing BMI, to the point that closing value may even encroach, maybe more than the functional residual capacity. It may even encroach a normal tidal ventilation. So all this results in ventilation perfusion mismatch and later hypoxemia. These patients, because they have increased respiratory resistance and decreased lung compliance, these things may be aggravated during anesthesia, supine position, and if we fail to relieve the postoperative pain. In these patients, there is increase in oxygen consumption and oxygen CO2 production. So to maintain the normocapnia, these patients take rapid shallow breathing to increase the minute ventilation, and but it increases the work of breathing. So you can see a decrease in arterial oxygenation in these patients. That is, there may be decrease in PaO2. However, the PaCO2 and the ventilatory response to carbon dioxide may remain within normal limits. As these patients have decreased respiratory reserve, and due to the restrictive pattern because of obesity and increased body mass, it is very difficult to ventilate these patients intraoperatively. So there is a faster desaturation during following induction of anesthesia and during direct laryngoscopy. So they have an impaired ability to tolerate periods of apnea, and higher FiO2 is required to maintain acceptable levels of oxygenation. So these patients are prone for obstructive sleep apnea, and which means that there is a complete cessation of breathing for more than equal to 10 seconds, and hypopnea if there's reduction in airflow for more than 10 seconds. In both, there may be oxygen desaturation to up to 3 to 4%. And there is an index which is known as apnea-hypopnea index, which means the total number of apneas and hypoapneas per hour. If it is around 5 to 15, then it is mild OSA. If it is moderate, then the AHI is 15 to 30. And in severe OSA, the AHI is more than 30. However, to diagnose this, we need a polysomnography lab for definitive diagnosis of obstructive sleep apnea. In the physiological changes due to the obstructive sleep apnea may be arterial hypoxemia, hypercarbia, polycythemia, leading to systemic hypertension, pulmonary hypertension, and right ventricular failure. So if the long-term consequences of obstructive sleep apnea may lead to nocturnal episodes of central apnea, which is due to the desensitization of the respiratory center to the nocturnal hypercarbia. So in this OSA, there is only hypercarbia during sleep when there is obstruction of breathing. However, during the daytime, the carbon dioxide level normalizes. But in extreme cases, when there is obesity, hypoventilation syndrome, these patients show hypercarbia even during the daytime. So these are the extreme cases of obesity, and we have to be very careful if these patients demonstrate this syndrome, as even light sedation can cause complete airway collapse and respiratory arrest. So as we all know, the symptoms of for assessing the obstructive sleep apnea, and that is snoring, dyspnea, sleepiness during daytime, fatigue, and maybe sometimes mental changes may also be there. They may be depressed. So there is a stop bank questionnaire, which is used as a screening tool for OSA. And in this stop bank is the mnemonic. S is for whether the patient snores or not. T is for whether they feel tired. O is for have anyone observed that they have stopped breathing during sleep. And P stands for increased blood pressure. For bank B for BMI more than 35 kilogram per meter square. A is for age over 50 years. N is for neck circumference more than 40 centimeters. And G is for male gender. So if the OSA, the stop bank score is around 5 to more than 5, then it is in high risk of OSA. And if the score is between 0 to 2, there's a low risk for OSA. So in patients, you can screen this in your PSC clinic before they come, before the sleep studies have been done for these patients. They may also have autonomic nervous system dysfunction, especially those patients who are diabetic, because these patients are more prone for hemodynamic instability during the perioperative period. And these patients are also prone for pressure sores and nerve injuries. In the gastrointestinal systems, the liver is involved. They may be suffering from non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. They are more prone for gallstone disease and delayed gastric emptying and gastroesophageal reflux disease. There is a risk of DVT, and if in these patients and those undergoing surgery, the risk is doubled. So it is mandatory to give DVT prophylaxis in the perioperative period. And their musculoskeletal system is also involved. They may have joint pains and arthritis. So while positioning these patients on in the OT, extra care is required. Pressure points need to be protected. There is an increased risk of rhabdomyolysis from pressure on the gluteal muscles, which may lead to renal dysfunction. So when central obesity is present with any two of the following, like dyslipidemia, decrease in high density lipoprotein, raised blood pressure, or impaired fasting glucose, or previously diagnosed type 2 diabetes, then this syndrome is metabolic syndrome. Now, what is its significance? It doubles the cardiovascular risk in these patients if this metabolic syndrome is present. So apart from diabetes, hypertension, CAD, and respiratory effects, these patients are more prone for cancers and may have the reproductive dysfunction, and liver and gallbladder may be involved. So other consideration in these patients are medications. So obviously these patients are on oral hypoglycemic agents, insulin, antihypertensive agents, statins, and if they are hypothyroid, they are on thyroid supplements. So what other medications they are in? So they are, most of them are maybe taking anti-obesity drugs like orlistat, liraglutide or semaglutide. These are GLP-1 agonists. So the anesthetic implications of these GLP-1 agonists is that they delay the gastric emptying. So there is an elevated risk of aspiration or regurgitation and aspiration. And many patients are taking many herbal medications, that over-the-counter medications. So you must make sure that you inquire about these medications before in the preoperative evaluation. Because all these anti-obesity drugs and over-the-counter drugs may lead to hypertension, stroke, and seizures. So they need to be withheld prior to surgery. Another important aspect is the airway assessment. We know how to assess. The routine assessment is like modified Mallampatti, temporomandible joint assessment, intercisor distance, etc. The neck circumference is one of the most important assessment for when you are assessing the airway. And if it is more than 40 centimeters, then there is an increased risk of difficult airway. And another tool, if you have an ultrasound with you, then you can see the pretracheal adipose thickness at the level of vocal cords. If it is more than 2.5 centimeters, it is a predictor of difficult intubation. So it is very important for airway assessment, because we know that the apnea time is less, and even with difficult airway, we need a prolonged apnea time. So we have to tackle all these things in the preoperative period. So this is a figure which is showing how you measure the at the level of vocal cord, the pretracheal adipose thickness. So, and we should also see whether there are obligate mouth breathers. So there may be hypertrophic tonsils and adenoids. So this is very important. RAM position is important in the intraoperative period. As you can see, this is how it, when you position in them without a ramp position, when you position in the by putting pillows or bolsters or a ramp position, we get this preformed structures. So we can use this, and in this the sternum is aligned with the external auditory meatus, so it helps in making the intubation easier. So other consideration in these patients is the proper bariatric table. OT table should be there along with it accessories. We should be aware whether the venous access or the arterial access is difficult or easy. And we should also consider the need for neuromuscular block monitoring, monitoring of BIS and CBP monitoring. Difficult airway cart with video laryngoscope should be ready. And we should have a proper size NIBP cuff. Extra padding and straps may be required, because for bariatric surgery, reverse Trendelenburg is done for this. The patient has to be strapped to the table. And so we need strap for this and accessories for RAM position. And we should have a protocol for pain management in there. Regional anesthesia will be taken later. For just in brief, that it is challenging, technically challenging. We need special equipment, special long needles and epidural needles. And we must remember the local anesthetic requirements are lower in these patients. And it is difficult to predict the level of sensory anesthesia. And blocks above T5 can cause cardiovascular collapse. So coming to the other consideration, that the dosing of drug is very important in these patients. There is a separate lecture for whether the inhalational is better or IV is better. But in brief, opioids and other induction agents these patients show exaggerated response with these agents, and especially with the patients who have OSA. And dosing is usually based on total body weight, ideal body weight or adjusted body weight, depending on the agent. And this is the formula for the ideal body weight. It is different in men and women. And lean body weight is the body weight excluding the fat mass. It is usually exceeds the ideal body weight, and it plateaus at around 80% of the total body weight. Approximately, it is 100 kg for men and 70 kg for women. And adjusted body weight is ideal body weight plus 40% extra. So we know we will be talking about this later, the drugs we are using for induction, whether RSI has to be used with succinylcholine or rocuronium, depending on the difficulty in airway, or whether we have aspiration, risk of aspiration. And agents, short-acting inhalation agents, desflurane and sevoflurane, or total intravenous anesthesia. It preferred, Tiva is preferred by few prefer inhalational agents, and many prefer short-acting opioids, that remifentanil or fentanyl, and opioid sparing techniques have also been tried. So this is a table which is showing that most of the drugs are dosed with the lean body weight, and succinylcholine low molecular weight heparins are based on the total body weight. And for propofol infusion, neostigmine and sucamadex and some antibiotics, adjusted body weight is used. So as far as fluid management is concerned, it is very, very tricky. And it is because it is very difficult to assess the fluid position in these patients due to the excess adipose tissue. It may mask the peripheral perfusion. So the main dictum is to maintain normovolumia. And as it avoids hemodynamic instability, post-operative nausea, vomiting, and acute tubular necrosis in the post-operative period. So it is usually rapid infusion of IV fluids are avoided. especially in those which pre-existing congestive heart failure was there, or they are treated for that. And ideal body weight are used for calculating the fluids, and appropriate monitoring may be there. So if you have a cardiac output monitor, you can use it if so for the fluid assessment. Beat to beat variability, heart rate variability can be used. And because it is a double-edged sword, if we give more fluid, then it may go, they may go, fluid overloading may be there. And if we give less fluid, then there are risk of ATN, acute tubal necrosis. And in patients who are super obese, with the patients who have prior history of renal disease, patients with intraoperative hypotension and prolonged surgical times more than 3 hours, there are risk factors for ATN. For ventilation, as far as ventilation is concerned, intraoperative ventilation, you can use pressure controlled or volume control mode, the mode which you're most comfortable with, and you aim for the lung protective strategies. Use total volume load around 6 ml per kg ideal body weight. We have to use PEEP. PEEP is required moderate to high PEEP, that is around 8 to 15 centimeters of water for proper oxygenation. And on top of that, if you're doing laparoscopic bariatric surgery, which is the norm nowadays, PEEP is the answer to maintain the PaO2. However, high PEEP may lead to hypotension, so you have to be very careful when you're using PEEP. And in between recruitment maneuvers should be done, and intermittent recruitment should be done. It can be done. One of the ways is to do a sustained inflation to 30 to 40 centimeters of water for 30 to 40 seconds. However, it may lead to hypotension, so you have to be careful. And FiO2, you may require a higher FiO2 in these patients. And it is advisable to avoid 100% oxygen requirement, oxygen in these patients. And SpO2 should be maintained more than 92 to 94%. The respiratory rate is adjusted to maintain a normal EtCO2 around 35 to 45 millimeters of mercury, and plateau pressures should be maintained around less than 30 centimeters, and the driving pressures below 15 centimeters of water. So as extubation in this patient is equally tricky, because we need a fully awake and alert patient, especially in super obese and obese grade 3 and 2, and hemodynamic stability, which is, I think, common for all extubations, but especially in these patients, they should be fully awake and alert with SpO2 of more than 95%, with an acceptable ABG, and with good Braille control and normal laboratory parameters. So coming to the end, I would just like to summarize that the main crunch and anesthetic consideration starts in the preoperative period. We have to optimize these patients, especially for all the comorbidities like hypertension, diabetes. Apart from that, we have to take care whether there is a risk of regurgitation or not, any metabolic, they are suffering from metabolic syndrome or not, and they are prone for increased hypercoagulability, so there is a risk of perioperative thromboembolic event. And these patients may also have psychiatric problems like depression, reduced self-esteem, and social stigma. So we have to anticipate complications in these patients depending on the type of patients you have. There may be difficult mask ventilation or intubation, whether the patients are receiving CPAP or BiPAP prior to operation, whether, if they are having OSA or OHS, or these patients, whether they are having hypoventilation, or whether there is a risk of aspiration, any risk for delayed emergence, DVT prophylaxis, and postoperative respiratory depression. There are certain red flags. That means there are certain conditions in which you have to have a ICU bed arranged for this, and it should be kept ready, because these patients are should be sent to the ICU after the operation. Patients with poor functional capacity, with abnormal ECG, patients with uncontrolled BP, CCF, or IHD, patients with SpO2 less than 94% on room air, and if the bicarbonate levels in ABG is more than 27. Obese patients with previous DVT or pulmonary embolism, And if the stop bank questionnaire is more than 5 and there's a metabolic syndrome, there is a scoring which is obesity, surgery, mortality risk score, which tells you about the risk in these patients. So in this, they score the arterial hypertension, age more than 45 years, male sex and body mass index more than 50 kilogram per meter square, and risk factors for pulmonary thromboembolism. So if the score is more than 4 or more than 4, then the post-operative mortality is as high as 3.2%. So you have to be careful if these patients are having, this is usually seen in obesity 3, classified as stage 3 or super obese patients. So how will you optimize these patients? In a nutshell, you have to manage the comorbidities to the best of your efforts, and you should know about the nutritional and the weight management. Many of them are on the liquid diet for 2 to 4 weeks because they help in reduce the liver size and visceral fat, and whether they are having any nutritional counseling or not. Psychological assessment is also important in this patient to evaluate for depression, anxiety disorders. Pulmonary optimization is the crux to have a good post-operative recovery. So OSA management is important, and these patients are started or on incentive spirometry in the preoperative period. Venous thromboembolism prophylaxis is equally important, and prophylactic anticoagulation is given in the preoperative period. But however, in the intraoperative period, we use mechanical prophylaxis. So thank you so much for your kind listening. Any questions you can put on the chat box, and we will be happy to answer in the end of all the 3 lectures. So now I would like to invite Dr. Nishant Kumar, who is professor in our Department of Anesthesia, Lady Harding Medical College. And he will be speaking on the use of intravenous, conquering the consciousness dilemma for the obese, whether we use inhalational agents or IV agents or combination of both. Over to you, Dr. Nishant.
Thank you very much, ma'am. Thank you for making my job easy, because ma'am has shared all the problems that you can face with an obese patient. Now, as the thing goes, that it's easy to anesthetize a patient, but difficult to wake the patient up. And the end point is that if we are anesthetizing the patient, we should wake up the patient as well. So the main thing is that once what we do for a normal patient may not hold true for the obese. So the question is, the burning question, in fact, is whether to use gas for these obese patients or the syringe. That is, we go for the traditional inhalational anesthesia or we go for the total intravenous anesthesia. Seems simple, an easy choice to make. It's simply the inhalational versus the total intravenous anesthesia. It looks simple, but there is more to it. So let's see. All these patients will definitely receive a general anesthetic. Now, once we come to the inhalational limb, okay, that is the standard that we practice. All our patients receive an induction with propofol or thiopentone or an IV drug, and we maintain these patients with inhalational anesthetics. Is it so? What for the obese? So for the obese, again, we have 2 options. We have got either the sevoflurane and the desflurane. I'm not talking about the earlier agents, halothane and isoflurane, hardly used in practice. Halothane is, totally out. Isoflurane, yes, to a certain extent, but then given a choice between isoflurane and sevoflurane, I'm sure most of you would go for sevoflurane, but desflurane was a game changer. Now, we all know that these patients have a high fat content. Now, most of the inhalation agents over a period of time tend to get deposited in the fat, and their recovery is dependent on the oil gas and blood gas coefficient. So we all know that the blood gas coefficient of sevoflurane is 0.69, whereas that of desflurane is 0.42, even lesser than nitrous oxide. One more thing, nitrous oxide, as far as possible, is avoided in these patients. It's better to use a combination of oxygen and air. And as ma'am said, that you may require a higher FiO2 to maintain saturation in these patients as well. And why use nitrous oxide and rest these patients for postoperative hypoxia? So it's always better to use a combination of oxygen and air. coming into this thing now, desflurane came in as a very good agent, quick in, quick out. The patient wakes up very clear headed recovery. We know sevoflurane, the old one, again was touted as quick in and quick out, faster than isoflurane and halothane, of course. But then it was sevoflurane was sweet swelling, hardly any respiratory complications. Desflurane is associated with respiratory irritability, laryngospasms, and some amount of emergent delirium, if at all. True with both sevoflurane and desflurane. So let's see. Now, when desflurane came, it came as a boon for the bariatric surgery and anesthesia. Is it really so? Let us just examine the evidence. So, this was this in 2013, right from ma'am was one of the authors for this. Hemodynamics and early recovery characteristics of desflurane versus sevoflurane. So if you see here, the painful stimuli, sevoflurane and desflurane. Now, if you see all these figures, the difference is hardly 3 to 5 minutes at all. Desflurane definitely better than sevoflurane, but a difference of around 5 minutes. And in the PACU, if you see, the Aldrich score was almost similar without any difference at all. Digital symbol substitution test, yes, again, a difference of around 7 to 8 minutes. So in all, desflurane does cause an early recovery with a difference of around 3 to 8 minutes. Let's see some other evidence. Now, some of you might say that it is quite old, almost 12 years old, 2015. Now, if you see that post-operative recovery, this was a meta-analysis of controlled trials. There was absolutely no difference in the Aldrich score. Slightly better recovery, again a 3-minute better recovery with desflurane. But when it came to the clear-headedness and ward readiness, there was absolutely no difference between the two. Another one, this one is from AIMS, New Delhi. And again, if you see here, the eye opening is approximately 6 minutes earlier. Aldrich score is almost similar. It favors stress, hardly half a minute or so. Now, if we think of post-operative nausea and vomiting, again, there was absolutely no difference in sevoflurane and desflurane. Now, when vomiting becomes critical in these patients, since the stomach has been operated upon, if the patient retches or vomits, then there's always a fear of sutures giving way and the pressure on the stomach. So yes, that is a really worrisome, but then again, a hardly difference between the two. Now, this study is interesting, again from India, a pretty recent one. Now, if you see here, they said that desflurane was in fact slightly, if you see, the patient woke up a bit later than sevoflurane. So they have said that sevoflurane is better. So hemodynamics and recovery profile, further recent. Again, if you see, the difference is hardly around 4 to 5 minutes. So now the question again arises. Desflurane, we know the negatives, it's costlier. We need a special vaporizer. That is true for sevoflurane also, but then you need a separate electrical connection, then the risk of laryngospasm, slightly higher risk of postoperative nausea, vomiting with desflurane as compared to sevoflurane, and then the environment cost that we are subjecting our earth to using desflurane, although gas flows. Now, FDA has not reduced, it has reduced from 1.2 to 0.8 liters for 2 mAh for sevoflurane. But the ASA and the European Society has come out that you can use sevoflurane safely, provided there is no incumbent renal pathology which is there, or if the patient does not have an AKI or chronic renal failure, then you can go with minimal flows as low as 500 ml fresh gas flows for sevoflurane as well, without any adverse effects. So with that, the choice is open. I mean, a difference of 5 to 8 minutes, that is all but what we are gaining with desflurane at a higher cost, and a higher cost to the environment, and an increased risk of postoperative nausea and vomiting. So that is the difference between desflurane and sevoflurane. Okay, now let's come to the other arm. So that was the inhalational. The debate was between desflurane and sevoflurane. Desflurane, yes, slightly better, but then sevoflurane equally good. Okay, now if we come to the debate between inhalational and total intravenous anesthesia, I'm not talking about modes of total intravenous anesthesia. This is simply a debate between whether to use inhalational anesthesia or total intravenous anesthesia. Now, recovery double-blind randomized control trial. Now, if you see that propofol and dexmed is a better anesthetic regimen than inhalation anesthesia using desflurane, better post-operative recovery with fewer post-operative side effects with TIVA. Now, this is 7 years old. Let's look at some other evidence. Now, this is a PONV study meta-analysis and 682 patients, and they have definitely said, as we all know, that TIVA has definitely a lower risk of postoperative nausea and vomiting. So this has definitely, when we talk of postoperative nausea and vomiting, TIVA is always going to be the winner when compared to inhalational agent. Now, this one is another study from Indonesia, and they have said that TIVA is faster recovery than inhalational, and the opioid requirement was much lower as compared to the traditional inhalational anesthesia. So again, TIVA comes out to be the winner. As I said, it's not so simple as it seems. Again, a study from Gangaram Hospital. Now, they have said that CLADS, when we add CLADS to TIVA, so desflurane with respect to depth of anesthesia consistency, post-anesthesia recovery profile, and definitely that is the future when the AI is taking over maybe our jobs. We don't know as yet. But yes, definitely CLADS is another feather in the cap of total intravenous anesthesia. Another meta-analysis, systematic review, and 12 RCTs, now 1,000 patients. Now, everything with inhalational and TIVA was similar except for PONV, which was definitely lower with TIVA. So again, whether you use inhalational anesthesia or you use TIVA, the results are the same. But yes, the surgeon is going to be happy that the patient is not trashing and throwing away merrily. So that is there. This is the latest from the Italian Society, an updated systematic review and meta-analysis of randomized controlled trials, 2025. So they have just used 13 studies with 1,072 patients. And they have said, again, all the other outcomes between TIVA and inhalation agents were similar, except for a reduced incidence of PONV with TIVA, as we all know. Now, the verdict is clear. Now, when we come to TIVA, so how do we administer TIVA? Whether we give a weight-based manual using the syringe infusion pump, or we go for target control infusion. Let us see again. So, safety and recovery profile of patients after inhalational anesthesia versus target control. Now, this is a 3-prong, and this is a risk analysis study. They have studied the grade 3 and grade 4, this thing. Sorry for that. Yeah. So, this study will come to later. Now, when we come to TCI, now we all know that TCI is definitely better because when we are dealing with manual infusions, we have to change the concentration depending on the base. The lines get disconnected and all. TCI is simple. We enter the target values for the plasma concentration or the effect site, and the pump does the rest. We don't have to calculate. I mean, if I had to do maths, I would have been an engineer, not a doctor. That is what made me turn towards biology. That is something that I cannot do maths. But unfortunately, as an anesthesiologist, we have to play with figures, and there are many chances of error when we are doing these manual calculations. So TCI does the job for you. Again, TCI, not so simple. We have the classical Minto, which is the plasma site model, the Schneider, which is the effect site, and the Eleveld, which fits everything. So then effect site model from the neonates to the elderly, from 600 grams to 200 kgs, Eleveld is the thing to go to. One model which fits all. It's a free size, which can be used for each and every patient. Now, the problem is that Minto, as we said, is a plasma. We know that effect site is better than plasma. Schneider, the problem is, we'll come to that. In fact, the Schneider, the problem is the moment you enter the height and weight of the patient and it goes beyond 30, the Schneider says, no, I cannot do this because the calculations go haywire, the body weight calculation go haywire and the algorithm is not suited for your obese patient. So Schneider, you can use with a rider, as we'll see a bit later. So when we go for, let's see the Marsh, this one. So as I said, that no adjustment versus adjustment formula. Now, as we know that in the obese, it is the weight which is the problem. So which weight to put? If you put a total body weight, definitely when we use the Marsh model, plasma concentration, the hemodynamic hit is going to be very high. Now, if we adjust the weight with this is the calculated body weight, which is ideal body weight, plus 0.4 into total body weight minus the ideal body weight, where the ideal body weight is calculated by 22 into height square in meters, we get the calculated body weight. And this formula works very well for the TCI models. And once we put this in the Marsh, yes, we definitely can use this Marsh and diminish the hemodynamic hit. The next one, as I said, Schneider. Schneider, as you can see, it uses the James formula. Now, if you see here, it calculates the lean body mass. So the moment your total body weight goes above 110, above 100, your James formula actually decreases the lean body mass for that patient. So you'll be giving much less propofol with the Schneider model, again, which won't be acceptable, and your calculations would go haywire, the patient wouldn't go under, the patient would be light, and there would be problems. So either we use the Jan Heischetten formula, or we use the calculated body weight in the Schneider. So in a sense, we are fooling the Schneider algorithm to deliver what we want, and the calculated body weight works well with the Schneider model for your obese patients. So if you want to use an effect site, this thing, and you have an older model of TCI pump, yes, you can go with Schneider, but with weight adjustments. Now, the first thing which came up was your Cortinez model. Now, again, this uses a correction factor of 0.4, as I said, the Sabin's formula or the corrected body weight. And that is what this model was based on. And it is used to use the target C. Unfortunately, not many pumps have this model. So you can use the standard model, enter this particular weight, and use this in lieu of the Cortinez model, which is a dedicated TCI model for the obese. Now coming to LFL. So it's a universal model, I said, from the thin to the fat, from the neonates to the elderly. It's with free fat mass, is fat-free mass is used. Again, the formula is complex. The pump does the calculation. All we have to enter is the age, weight, height, and sex of the patient. And the beauty of LFL is that it maintains and it is titrated to BIS, basically. So you end up using much less propofol and it correlates with BIS. So if one model that I have to suggest, if you have it, you go for LFL. If not, Schneider with the weight adjustment is the second model to go to. Now, as you can see here, this is the infusion rate. And as the time goes on, if you see here, the LFL and Marsh adjusted body weight and the Cortinez are almost similar. So in any ways, whatever model that you're using, the Marsh or the Schneider, which are not meant for the obese, you'll have to adjust the body weight for these models. If you're using elevated or Cortinez, you just enter the total body weight and you're good to go. So if we see the performance of TCI models, again, the LFL, as I said, is the best, and adjusted body weight, if you use with Schneider and Marsh, is good enough. Now, this is the risk-benefit study which I was talking about, obesity and anesthetic pharmacology. Now, if you see here, grade 3 and grade 4, the adverse events. Now, this was definitely highest with the Marsh, lowest with Schneider when we talk of TCI, and manual OK 1.03. So, non-committal. But then when we compared the manual and the TCI, obviously the TCI was better. Inhalation was better than TCI when it came to the adverse events, although not much. The outcomes, if you look at outcomes, PONV, as usual, the TY is favored. Time to reach a recovery score, inhalation anesthesia is favored, but then the difference is not much, hardly a difference of 5 to 10 minutes. If agitation and emergence, again, better with TIVA. Cost, cost, when we talk of, definitely propofol turns out to be a bit costlier than your inhalation anesthesia. But when you talk in terms of the equipment, the electricity cost, the plastic waste, and the environmental burden, then again there have been studies which show that TIVA or TCI is definitely better than using this desflurane for any anesthesia in these patients. Okay, now we have talked about inhalational and TIVA. We have talked about TIVA inhalational. Obviously, the DES is better. Sevoflurane, okay. I would say they are both equal. I would still prefer using sevoflurane to desflurane. And then when we talk of total intravenous anesthesia, obviously I'll prefer using a TCI model over the manual method. And when it comes to the TCI, I'll definitely prefer using a Cottiners or an Elwell model. But if I have an older pump, I'll use Schneider using the weight adjustment. Now, another thing is opioids. We all know, as ma'am said, that these patients are very sensitive to opioids. There is additional risk of respiratory depression, which is there. So morphine or longer acting opioids are out. So when we talk of opioids, now again we have two things. So as I said, it's not so simple whether to use fentanyl or remifentanil. By the looks of it, remifentanil definitely looks promising. Switch on, switch off. The moment you switch off, the effect is gone. But then remember, so is analgesia. Now, fentanyl, when you give it as an infusion, definitely the context sensitive of fentanyl, half-life of fentanyl is high. So you have to be careful whether you're giving fentanyl via boluses or as an infusion, because it has a tendency to accumulate. Remifentanil does not accumulate, but then at the end, then there is no analgesia, and you have to give a longer acting opioid or a multimodal analgesia, as we'll come to it a bit later. So now the thing is whether to give remifentanil manually or again using a TCI, because it is being given as an infusion. Now this is an interesting study, quite a recent one, and they have said that when it was injected using the manual methods, the requirement was a bit high. Remifentanil requirement was a bit high, but the recovery was faster. Now, this is an irony which is there, but that is what this study has found. That, but then the sample size is only 31, so that could be the limiting factor. But then, yes, they have said that if you give remifentanil using manual calculations, that is better than using TCI. So again, a pinch of salt for that. Again, as we say, this is a systematic review. Now they have said that they could not find any major advantage of using remifentanil over other opioids in bariatric surgery. So again, the verdict is open. We still need to study a bit more on remifentanil now that remifentanil is available in India. I'm sure we'll be seeing indigenous studies and how these drugs behave with our population and with our obesity pattern. So again, that is something to be seen, whether there's a gender or a racial difference, which is a geographical or racial difference, which is there with these drugs, and that we have to study. Now, one thing is the traditional opioids approach. The second thing is the opioid sparing. Now, opioid sparing is where you add some other modalities of analgesia and you reduce the traditional opioids that you're using. So we all try to do that for bariatric analgesia. Now, the third one, the interesting is you don't use opioids at all, or what is being touted as opioid-free anesthesia. So from the beginning till the end, no opioids are used. So we have two obvious choices for this. Again, when we compare opioid-based and opioid-free TIVA for laparoscopic urological procedure in obese patients, now they have said that opioid-free anesthesia is safe, can be used, and post-operatively, opioid requirement is much less with this group. And obviously, lesser PONV. When you're giving opioids, you're increasing the risk of PONV in these patients, again, which I said is not very good. Then opioid containing versus opioid free, comparing opioid free general anesthesia to traditional balanced general anesthesia, and performance of opioid free anesthesia for bariatric surgery in clinical practice. Again, they have said that the recovery is faster with opioid free, and the opioid requirement in the postoperative is much less. So these are pretty recent articles ranging from 2022 to 2023. Now, this article, again, this article and this one, Opioid-free anesthesia for laparoscopic gastroplasty, non-opioid versus opioid-based general anesthesia technique for bariatric surgery. And this is again a recent one, opioid-free versus opioid-based strategies during multimodal anesthesia on postoperative morphine consumption. Now, these articles, they say that both are equal. There's not actually much of a difference whether you use an opioid or you don't use an opioid. So, but yes, definitely the PONV is definitely less with the non-opioid or the opioid-free strategies. Again, this one from 2023, they have said the hemodynamic hit with the opioid-free is a bit higher as compared to the opioid-based anesthesia. Dexmedetomidine, we know, causes bradycardia and hypertension. Ketamine, we know, causes a bit of hypertension. So again, this one is on 2025, a pretty recent one. And this one was in 83 patients, opioid-free or remifentanil. And they have said that the intraoperative antihypertensives were more required in the OFA group as compared to the this thing. So we have now
The time is 8:00 p.m.
opioids. If we go for no opioids, you have the dexmed and ketamine, which can replace your remifentanil and fentanyl. Coming to the two, whether you use ketamine or dexmedetomidine, the need of intraoperative fentanyl was reduced. And again, the improved recovery scores and PONV scores with the dexmedetomidine. Ketamine decreased postoperative NR scores, and they said that the need for postoperative opioids was definitely lesser with ketamine as compared to dexmedetomidine. But yes, we can use either of these. We have been using, in fact, an opioid-free technique, exclusive opioid-free technique for us in ROTs, and we use a multimodal analgesia technique, as I'll come to it later, and we'll be talking about it in the next topic as discussing as the next topic. So a lot of scope, a lot of things yet to be known. We still don't know how these drugs behave in the obese patient. And with the techniques coming up, remifentanil now being available in India, we still have to know quite a lot, and we have to learn quite a lot before we can definitively say, okay, this drug is to be used in obese, this drug is to be avoided. So just to recap, if we giving GA, we have inhalation versus TIVA. If we go for the inhalational technique, we have desflurane or the sevoflurane, pardon the spelling of desflurane, a typo. So 5 to 8 minutes earlier recovery, desflurane is definitely your choice. TIVA, weight-based or manual infusion versus TCI. Now we know that TCI is definitely the thing to go to. The 4 models, Minto, Schneider, Cortines, or Eleveld. Given a choice, I'll have Cortines and Eleveld, which are specifically for the obese. Schneider with modification Marsh, probably I would not use for the obese. Now, whether to use opioids or not, again, fentanyl or remifentanil. So what do we do? Again, there has been no difference. There's been no evidence in that. Opioid sparing, yes, definitely preferable. And when we go for no opioids, we have dexmed and ketamine. The verdict is still there. We are not sure what is to be done. I mean, the studies have to be done for that, whether dexmedetomidine is better or ketamine is better. Now, with all these paraphernalia, we have certain other things which can be added. Magnesium sulfate in a dose of 30 to 40 milligram per kg is a definitive analgesic which can be used in this patient, reduce the requirement of opioids. And lignocaine as a bolus of 1.5 milligram per kg and an infusion, continuous infusion. Whenever lignocaine is added to any of these regimens, that has shown better recovery profiles and better postoperative analgesia. And definitely, we can use regional analgesia for these patients, although difficult. But then with the advent of ultrasound, facial plane blocks, although they might have to be given bilaterally, as we'll be discussing, can be added to all these regimens and decrease the opioid requirement and the analgesic requirement, and improve the postoperative recovery, faster and better recovery in these patients. So there's a lot to know, there's a lot to learn, and we have to be inquisitive. We have to be with the technological advancements. We have to be inquisitive, and we have to know which one suits our patients the best. These might seem difficult, but everything is difficult unless you practice. And once you practice, nothing is difficult. With the technical advancements, we have to advance, because this was also anesthesia once upon a time. Thank you so much.
Thank you, Dr. Nishant, for such a elaborate presentation. And I need to do a correction. Dr. Nishant Kumar is Director Professor in Department of Anesthesia and Critical Care, Lady Harding Medical College. So,
I'll always be your
my
student.
apologies, Nishant.
I'll always be your student, ma'am.
It's all right, but I should give a correct designation. So next, I would like to invite Dr. Ayushi Yadav. She is a senior resident in the Department of Anesthesia, Critical Care, Lady Harding Medical College. She will be talking on the regional anesthesia techniques for bariatric surgery. Dr. Ayushi, the screen is yours now.
Thank you, ma'am.
Please share your slides.
Yes, ma'am. Good evening, everyone. I am Dr. Ayushi, and I'll be talking about the regional anesthesia techniques for bariatric surgery. Is one better than the other? So why do we need regional analgesia? Even despite with increased use of laparoscopic bariatric surgeries, the patients often experience intraoperative and immediate postoperative pain, which is moderate to severe in intensity. So regional analgesia, it forms a part of multimodal analgesia and ERAS protocol. When adequate analgesia is achieved, it helps in early mobilization, which reduces the thromboembolic complication, as well as it helps in decreasing the need of opioid consumption, decreasing the reduced pulmonary complication, which obese patients are prone to. So these are the different techniques of regional analgesia. We have transversus abdominis plane block, quadratus lumborum block, rectus sheath block, erectus spinae plane block, paravertebral block, and epidural analgesia. So we'll be discussing each of the block one by one. Starting with transversus abdominis plane block, it is a block which is given between internal oblique and transversus abdominis muscle. Since it is a USG guided block and it covers T7 to L1, it targets all the sensory nerves of the anterior abdominal wall. It is technically simple, feasible, and minimally invasive, and has a longer duration of action. It helps in decreasing opioid rescue administration, consumption, and post-op pain score. Now, in obese, we know we have thick subcutaneous abdominal fat, thick adipose tissues are there. So difficult visualization is one of the problems using ultrasound. This block needs to be given bilaterally, so obviously it takes a little time, and it only covers the somatic component of the pain. So it is more suitable for laparotomies like open bariatric surgeries rather than laparoscopic surgeries. So in the figure, we can see the three muscle layers: external oblique, internal oblique, and transverse abdominis. And the drug is given between internal oblique and transverse abdominis muscle. In figure 2, we can see the nerve roots, the dermatomes, which are covered by the tab block from T7 till L1. Coming to the second block, quadratus lumborum block, in the subcostal anterior approach of this block, at the level of L1, L2, it covers the dermatome from T6 till L2, and it is given between quadratus lumborum and thoracolumbar fascia. Now, quadratus lumborum block, it is deeper in location and it allows greater paravertebral diffusion. Now, because of the paravertebral diffusion, it affects the mechanoreceptors and pain receptors in the thoracoabdominal fascia. It has rapid onset, has prolonged duration of action, and it is a broad block. It helps both in visceral as well as abdominal wall incision pain. Again, this block needs to be given bilateral, and it needs a higher expertise compared to the transversus abdominis plane block, which we mentioned earlier. Since a high expertise is required, so it is time consuming. Again, as it is a deeper block, so visceral injuries and quadriceps femoris weakness is quite common. The research data is very less regarding quadratus lumborum block used as a single means of regional analgesia in bariatric surgeries. So in the figure, we can see the quadratus lumborum. This is the quadratus lumborum muscle. This is the psoas major, and the drug is deposited between the two layers. This is the ultrasound view in which this is the quadratus lumborum muscle. This is the psoas major, and the anesthetic drug is deposited between the two. Coming to the erectus spinae plane block, erectus spinae plane block is performed at T7 to T8 level in the myofascial plane between the transverse process and the erectus spinae muscle. Now, when the drug is given in this block, it will affect both ventral and dorsal rami of the spinal nerve, and the sensory innervation of the entire anterolateral thoracoabdominal wall will be affected by this. Also, there is paravertebral spread in this block, which helps in somatic and visceral sensory blockade of the pain. Now, since this block is distant from the pleura and major neurovascular structure, so chances of pneumothorax and major nerve injuries is less. The major concern with erectus spinae plane block is that it is either given in sitting position or in the lateral position. So in both these positions, we need to perform these block before giving general anesthesia to the patient. So the procedure of the block itself might be painful for the patient. This block again needs to be given bilaterally, and again due to increased subcutaneous fat and adipose tissues in the obese patient, there is difficulty in identifying the muscles and the transverse process. In figure 4, this is the schematic representation. In this, we can see this is the transverse process, this is the erectus spinae muscle, and the drug is deposited between the two layers. In figure 5, we can actually see that when the drug is given, it goes to the sympathetic ganglion, the ventral ramus, and the dorsal ramus, and it affects the sensory innervation at these areas. Coming to thoracic paravertebral block, it is a wedge-shaped area on the either side of the spine. We give this block either from T6 to T12 level. The drug will diffuse widely along the vertebral bodies and the epidural space and provide sensory, motor, and sympathetic nerve blockade. Again, this block needs to be given bilaterally, and it is near to the pleura, so chances of pneumothorax and nerve injuries is higher than compared to the other blocks. Again, due to increased subcutaneous tissues, there is difficulty in visualizing the structures using ultrasound. So this is the transverse process, this is the pleura, and this is the wedge-shaped area in which this is the paravertebral space in which the drug is deposited. You can see here also the blue area represents the paravertebral space where the drug is being deposited. Coming to rectus sheath block is the block which is given anterior to the posterior rectus sheath and not within the rectus muscle. It covers from T6 to T11 dermatome, and all the midline abdominal surgeries from xiphoid to symphysis pubis, the pain cover is very good with rectus sheath block. But this block alone is not efficient. We need to combine it with other blocks such as tab block. This block needs to be given bilaterally, and the rectus sheath itself is a very large area, so large absorption area is present. So the quantity of the drug required in this block is higher as compared to the other blocks. Also, due to epigastric arteries in the vicinity, inadvertent intravascular injections can be a concern with rectus sheath block. So this is the rectus abdominis muscle. This is the posterior rectus sheath, and the drug is deposited here. This is the ultrasound image of it. This is the rectus sheath, posterior rectus sheath, and the blue area is showing the deposition of the drug. Now coming to epidural analgesia. Epidural is when for bariatric surgeries, thoracic epidural has shown it's quite good for the analgesic part, more for laparotomy, open bariatric surgery compared to laparoscopic bariatric surgeries. It is a central neuraxial block. It is given at a single site, and generally ultrasound is not required to perform this block. In postoperative period and intraoperative period, opioid requirement decreases, and epidural also helps in early ambulation and shorter hospital stay. But again, due to increased subcutaneous tissue and fat, it is difficult to identify anatomical landmarks for performing epidural anesthesia. A longer needle may be needed because of the, again, increased thickness of the fat layer. And sometimes due to pressure or movement of the excessive fat, even if the epidural has been performed at the right place, the catheter displacement can be there. So we might require catheter replacement later or after a day or so. Also, since it is a central neuraxial block, so stringent requirement of blood coagulation profile is a must when coming to epidural analgesia. There are some risks associated with epidural analgesia, like the epidural site infection can be there. It causes hypotension as we give the local anesthetic drug through the epidural catheter. Placement failure, as I told, because of the excessive movement of the excessive fat tissue, and potential neurological complications can also be there. So which technique is better? Which technique should we choose for bariatric surgeries? Now discussing all the blocks and the epidural analgesia, it has shown, several studies were done, and it was shown that erectus spinae plane block, quadratus lumborum block, and the tab block, they are relatively safe. They're away from the pleura, and lower opioid consumption is seen intraoperatively and postoperatively. Erectus spinae plane block and quadratus lumborum block will cover both somatic as well as visceral component of the pain. Now, compared to the tab block is although feasible and minimally invasive, but will only cover the somatic component of the pain. Excellent analgesia is seen when the tab block is combined with rectus sheath block. Paravertebral block due to pleura lying near to the needling area, pneumothorax is common. Now, all these blocks are to be given bilaterally, whereas epidural, which is a single site, a single unilateral block. So the epidural, the problem with epidural is that it can be limited and unilateral, and patchy effect can be seen with epidural analgesia. So why do we need multimodal analgesia? We have been talking about multimodal analgesia. So why is it needed? So it is an integrated process where there is activation of numerous biochemical and anatomical pathways. So simultaneous use of multiple analgesic methods is needed in intraoperative as well as postoperative period. So following are the intraoperative analgesic methods which are used in bariatric surgery. We can use injection ketamine 0.1 mg per kg bolus followed by 0.1 mg per kg per hour infusion. We can use injection dexmedetomidine 0.1 mics per kg bolus followed by 0.1 mics per kg per hour infusion. We can also use magnesium sulfate up to 50 mg per kg IV to up till it offsets the sympathetic surgical response. And sir also discussed we can use lignocaine as well for the intraoperative analgesia. Injection paracetamol 2 gram IV can also be given, and injection diclofenac 75 mg IV is also given. So to conclude, regional analgesia, it forms a very important part of the multimodal analgesia and ERAS protocol, along with providing superior pain relief compared to opioids, decreasing the need for anesthetic consumption without much effect on hemodynamics. Thank you.
Thank you, Dr. Ayushi, for your wonderful presentation. Now I will be inviting Dr. Abhity. She will be talking on post-operative conundrum, how to ventilate and relieve pain in obese patients. Dr. Abhity is assistant professor at ABVIMS and Dr. RML Hospital, Department of Anesthesia, New Delhi. Dr. Abhity, please start your presentation.
A very good evening. Thank you so much, ma'am. Today I will be discussing about the post-operative problems, that is how to ventilate and relieve pain. So now, why do we need to optimize the respiratory outcomes? As we all know that obesity leads to a decrease in the functional residual capacity, the lung compliance, and also increases the atelectasis risk. There is also higher incidence of OSA, OHS, oxygen consumption, and the CO2 production both are increased. The shunt and the VQ mismatch will lead to an increased FiO2 requirements, and also the increased CO2 production and the impaired CO2 sensitivity will lead to an increased dependence on the mandatory ventilation and increased minute ventilation requirements. So the decreased compliance and along with the increased resistance will lead to increased ventilator pressure requirements. Now, very important is to consider the pre-extubation planning and what are the extubation considerations to have an uneventful post-operative period. We have to ensure the full reversal of the neuromuscular blocker. That is, we have to use the train of 4 ratio more than 0.9. Adequate pain control, that is with the use of minimal opioids, is preferred.
You,
Just
Abhity,
a
your
minute, you
slides
have
are
not
not
shared
visible.
your slide, Abhity.
You share your
Share
slides,
your
please.
slides.
Share your slides, please. Share your screen, beta.
Yes, sir. Actually, yes.
Yes, I was thinking that you're giving introduction, so I was waiting. So please, yeah.
Ma'am, now is
Yeah,
it?
yeah,
Sure.
Yes, yes, it is visible now. Yes.
Okay, ma'am. Yes. Ma'am. So yes, so now the pre-extubation planning, which is very important, it is done by the help of ensuring a full reversal of the neuromuscular blocker via using a train of 4 ratio greater than 0.9, the adequate pain control with the use of minimal opioids, normothermia, stable hemodynamics, and normal ABG. Head-up positioning, which is very important to optimize the lung volumes, and extubation to NIV or HFNC for high-risk patients. We have to also be very vigilant and prepared for early reintubation in the ICU or the post-operative unit. So now, next we have coming to the ventilatory strategies, what we prefer in the post-operative period in these bariatric patients. For low-risk patients, supplemental oxygen with close monitoring will suffice. For moderate risk patients, we have to consider high-flow nasal cannula or non-invasive ventilation prophylactically. For the that was moderate risk. The high-risk patients, we have to do a planned ICU admission, and delayed extubation is sometimes necessary. So NIV is prophylactically indicated in patients with a BMI more than 40, with comorbidities, history of OSA or OHS, or patients requiring home CPAP therapy, the ABG showing CO2 retention, and evidence of poor respiratory effort post-extubation. Now, this is a study which was done as a retrospective analysis that was titled as Non-Invasive Ventilation Reduces Post-Operative Respiratory Failure in Patients Undergoing Bariatric Surgery. And it concluded that short-term non-invasive ventilation in the post-operative period leads to rapid recovery of post-operative lung function and oxygenation in the obese patients. Now, there is another study that is titled the Non-Invasive Preventive Ventilation with 2 pressure levels in the post-operative period of Roux-en-Y gastric bypass that was done as a randomized trial, and they used two pressures to do non-invasive ventilation in these patients in the post-operative period. So, and they found that the recovery at the third post-operative day was better in these NIV groups in terms of inspiratory capacity and peak expiratory flow variables. Also, there were fewer complications in these groups. Now, there is another review regarding the intraoperative protective lung ventilation strategy in patients with morbid obesity. This article emphasizes the need for a low tidal volume along with moderate to low PEEP levels, use of laparoscopy, and prevent the absorption atelectasis and the oxygen toxicity. The FiO2 should be limited to maintain an SpO2 greater than 92%, ideally maintained between 0.5 and 0.8, and recruitment maneuvers which help to improve the oxygenation and also to maintain at least a 30-degree head-up position. All these protective ventilatory strategies lead to a good post-operative ventilatory outcome in these patients. Now, the other strategies to prevent respiratory complications, which are equally important, include incentive spirometry, early mobilization, chest physiotherapy to prevent atelectasis, encourage cuffing, deep breathing exercises, continuous pulse oximetry, and capnography. The ABG monitoring is also done if hypercapnia or acidosis is suspected, and early ICU transfer is considered if the NIV fails or there is respiratory fatigue. Now, coming to the pain management. Pain management can be challenging in this group of patients because they have an increased opioid tolerance. There is also an altered pharmacokinetics leading to difficulty in determining the effective dose of the drugs, and the opioid use in these group of patients can lead to respiratory complications like respiratory depression and hypoventilation, which can be counterproductive. So the strategies to overcome pain include multimodal analgesia, regional analgesia, individualized care that should be tailored to every patient need. Then monitoring of pain levels, respiratory status, and other vital signs. Now, multimodal analgesia, which is the preferred technique as has been previously discussed. So it says that a stepwise severity-based opioid-sparing approach is preferred. If opioids are required, they should be used in smaller and more frequent doses along with the respiratory and other vital monitoring. If IV PCA is required, then a combination of ketamine with morphine in a 1:1 ratio is preferred. In patients with diagnosed or treated OSA, there should be resumption of CPAP therapy if they are requiring opioid analgesia. Now, regional anesthesia has already been discussed in detail. Just to briefly mention that truncal blocks do provide extended analgesia compared to wound infiltration. And there are certain novel techniques that have been described in bariatric anesthesia that include intraperitoneal local anesthesia infiltration and surgical laparoscopic transversus abdominis plain block. Now, what are these advantages of using the regional anesthesia is they have a significant opioid sparing effect. They have high safety and efficacy and minimum patient-to-patient variability. Now, what does IRAS say about the management of post-operative pain in these patients? For laparoscopic abdominal surgeries, multimodal analgesia, including NSAIDs, COX-2 inhibitors, and acetaminophen are the modality of choice. Thoracic epidural analgesia has a weak evidence of being used in these patients. Intravenous lidocaine infusion has moderate evidence. Intrathecal morphine also has moderate evidence, and tab block can also be used, but has a moderate evidence of being used in these patients. So now, this is a table highlighting the risk factors for poorly controlled acute postoperative and persistent pain, along with the persistent need for opioid use in the bariatric surgical population. So now, the patients, like the younger age group patients, females, pain score greater than 3 on the arrival in the recovery, and poor pain control on discharge from the recovery are the risk factors for poorly controlled pain. Now, the patients who are prone to develop persistent pain in the following the bariatric surgery include patients with younger age, females, smokers, patients who are unemployed or have pre-existing symptoms. Now, the patients who are prone to persistent opioid use include the patients who had pre-existing pain, preoperative opioid or other analgesic use, preoperative anti-anxiety agents, hospital opioid use, prolonged postoperative non-opioid use, benzodiazepine use, smokers, subsequent surgeries, ethnicity, or patients who have marital status problem. So now, this is a figure that shows that preoperative preparation is very important for improving the postoperative pain management in bariatric patients. Now, how do we optimize these patients? How do we prepare them? It includes the medical optimization in terms of screening, diagnosing, and treating the OSA, and also identifying patients at high risk of postoperative respiratory adverse events. Then physical preparation that includes exercise, diet, weight loss, functional prehabilitation, and also psychosocial factors needs to be included. That is, we have to screen these patients for anxiety, depression, or and catastrophizing. That is, they need to be provided with specialist support if chronic pain or opioid use is already present. Then patient education, it plays a very important role. That is, we need to educate, engage, and empower these patients that what should be the pain management expectations. Also, the post-operative plan and the follow-up needs to be discussed with these patients. This helps to improve the post-operative pain management in these patients. Now, this is an article that is regarding the perioperative pain management in the bariatric anesthesia. So now that highlights that the use of structured, stepwise, severity-based opioid sparing multimodal analgesia protocol within an enhanced recovery after surgery framework can improve the post-operative pain management. Now, there is another systemic review regarding the perioperative pain control in this group of population, that is, which suggests that multimodal analgesia represented in preoperative, ultrasound-guided tap block, intraoperative port site and intraperitoneal infiltration with local anesthesia, followed by postoperative IV acetaminophen and patient-controlled analgesia, along with the use of preoperative clonidine, ketamine, pregabalin, and epidural analgesia may be used in these patients to control pain. Thank you so much for the patient listening.
Thank you, Dr. Abhity. And in the end, I would like to just add that it is very important to prepare these patients in the preoperative period, and so that you can do a proper risk assessment and optimize the comorbidities in this patient and plan for post-operative pain relief and also PONV. And of course, thromboembolism prophylaxis is equally important in these patients. So if we plan adequately and a meticulous anesthetic management in the perioperative period will go a long way to decrease the morbidity and mortality in these patients. Thank you. If there are any questions, we are ready to answer them. Over to the moderator.
No, ma'am, there are no more questions, sir. There are no questions, sir.
There are no questions?
No, ma'am.
So we can close the session.
Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ICA, for this opportunity. I hope it will benefit the residents and everyone. Thank you.
Thank you. Thank you, sir. Thank you, Maitree, ma'am.
Thank you. I would
Abhity.
like to thank the
Thank you.
president
Thank
and
you,
other
ICA.
office bearers of ICA for giving us this opportunity on this platform and hope to meet soon. Thank you.
Thank
Thank
you,
you.
ma'am.
Thank you.
Hello.
Thank you, ma'am.
Good
Hello.
evening, ma'am.
Good evening, ma'am.
Hi,
Evening, ma'am.
Saloni.
Yes, ma'am.
Should I conclude then?
Yes, ma'am. There are no
Maitree,
questions.
no questions. Maitree, naturally, it was so well explained as such an elaborate webinar. We've never had such a nice one earlier, covering every part of bariatric morbid obesity, basically the anesthetic considerations, then of course TIVA versus inhalation, regional anesthesia, and of course how to ventilate and then post-op pain. So such important topics covered so well by Dr. Maitree, Nishant, Ayushi, and Abhity.
Thank you, ma'am.
So I have no words to express my thanks. Thank you so much. And I'm sure while we too have got educated, the delegates have definitely benefited. Thank you, Saloni. Thank you
ma'am.
so much.
Thank you, ma'am.
Thank you,
Thank you,
ma'am.
ma'am.
Thank
Good
you.
night.
Thank
And
you.
see you all sometime soon in the
Sure, ma'am.
webinars.
Yes.
Sure.
Ma'am.
Thank you so much. Rimpa, thanks a lot.
Yes, ma'am.
And we could now close the session.
Okay, ma'am. Thank you so much, ma'am, for the wonderful session. ClearNet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session over here.
Thank you, dear. Thank you.
Thank you, ma'am.
Thank you.